Good morning, Dr. PK from Dr. PK Life. I hope you're having great Wednesday. And today I'm going to talk about a very important topic, and which is kind of confusing for a lot of people. And it's a very important topic. And this is for about diabetes. And the question is, someone asked me the other day, why isn't hemoglobin A1c always used to diagnose diabetes? Many people assume that hemoglobin A1c is the best and only test for diagnosing diabetes. It is very useful test, but it is not perfect, and that's why it is not always relied upon alone. So that's the thing here. It's not always relied upon alone. So I'm gonna break this down clearly. Hemoglobin even A1c test is very significant, but you cannot always solely rely on A1c, and this is why. So hemoglobin A1c measures percentage of hemoglobin coated with glucose, called glycated hemoglobin, because red blood cells live about 120 days, and that is 4 months, right? 120 days. So A1c reflects average blood sugar over last past 3 to 4 months. It's 120 days. Some people like, okay, gotta check it 2 3 months. Yeah, you can check it, no problem, but 3 months on average, 4 months even is fine. So what is the diagnostic cutoff for A1c? Now, by definition, if it is more than 6.5%, is considered diabetes. Now, 5.7 to 6.4 is called prediabetes. So why A1c is not always reliable for diagnosis? So here are the key scientific reasons. Number one, it does not measure current blood sugar. It's an average of last 120 days coating on hemoglobin A1c. So it's a memory. Someone may have a very high fasting glucose for 2 weeks and may have a normal blood glucose for 2 months. So in early diabetes, fasting glucose may rise before A1c changes. That's why fasting glucose or oral glucose tolerance tests are sometimes better early indicators. Now, number two, conditions that affect red blood cells. So what happens, because this blood test depends on the lifespan of A1c, what happens if red blood cells are being destroyed prematurely, or number of red blood cells are lower or higher? So you're gonna have a false low A1c if you have anemia like hemolytic anemia, blood loss for any reason, kidney disease when red blood cells are not forming the way they should, and after blood transfusion, and falsely high A1c if you have iron deficiency, anemia, B12 deficiency, and some hemoglobin variants. The thing is that if your RBCs live shorter, that means there's less time for glucose attachment. So you're going to have a falsely low A1c. If RBCs live longer, more glucose exposure to the surface of red blood cells, you're going to have falsely high A1c. Number three, ethnic and genetic variation. Some populations naturally have slightly higher A1c independent of glucose levels. A study shows African American, South Asian, and Hispanic population tend to have higher A1c at the same glucose level. And this can lead to overdiagnosis in some cases. Number four, not reliable in certain medical condition. A1c should be avoided or interpreted cautiously in advanced kidney disease, liver disease, pregnancy, recent acute illnesses, recent blood transfusion. In pregnancy, for example, we only use glucose tolerance testing for diagnosis instead. Early type 1 diabetes may be missed in rapidly developing type 1 diabetes. blood sugar can spike suddenly. A1C reflects average over months, so it may lag behind the true severity. That's why symptomatic patient need immediate glucose testing. So, what do guidelines recommend? Major organizations like American Diabetes Association and WHO state that A1C can diagnose diabetes, but results should be confirmed. You just can't take one test and like, oh, you have diabetes. There should be a sequential test, and it should be in the clinical context. What else is going on with patient? A diagnosis can be made with fasting plasma glucose more than 126 milligram per deciliter, 2-hour oral glucose tolerance test with more than 200 milligram per deciliter, or random glucose more than 200 milligram with symptoms of diabetes. Bottom line is this: A1C is convenient. It does not require fasting, useful for monitoring, but it is not a perfect test. It's affected by RBC disorders. It can miss early diagnosis, can mislead in certain population. In a real world practice, we use A1C and fasting glucose together. A1C, I personally use for follow up. I don't think I've ever diagnosed somebody with A1C as such, but many times I have patient coming after emergency room visit or in post hospital. First time they have been always diagnosed with A1C of 13, 12, 14, something like that. So it's easy. I don't even have to worry about the diagnosis part. But it's important for a doctor to know a complete metabolic picture. And so this video was about A1C. Please like it, share it, and repost it. And I will see you in next video. Thank you for watching.